Warm good evening to everyone here. I'm going to present a case of partially treated warped Koinagi-Harada disease masquerading as a solitary choroidal mass, which was a diagnostic challenge. Introduction, as we all know, warped Koinagi-Harada disease is a bilateral granulomatous panuveitic syndrome affecting the ocular, neurological, and cutaneous systems. It is caused by autoimmunity to the pigmented structures. Corticosteroids and immunosuppressants form the cornerstone in the management of VKH. Prompt diagnosis and treatment serves crucial to preclude visually disabling complications. The diffuse choroidal inflammation manifests in the OCT as subretinal membranes, high retinal detachments, and subretinal hyperreflective dots. Usually, the giant granulomas are being diagnosed as tuberculosis or sarcoidosis. However, atypical VKH disease can also present as a solitary large choroidal mass with exudative retinal detachment, posing a diagnostic challenge to the clinician. Here, a 23-year-old female presented to the outpatient services with progressive painless diminution of vision in the right eye for 3 days, associated with right-sided tinnitus and a refractory headache. There was similar complaints a month prior, for which she was treated with systemic corticosteroids elsewhere, defaulting which she developed the current episode. On examination, the base-corrected visual acuity in the right eye was 20 by 400, and in the left eye it was 20 by 20. Anterior segment examination of the right eye showed 2+ cells, 1+ flare and pigments over the anterior lens capsule with retrolental cells. The pupil was circular and reacting to light. There was no RAPD. The posterior segment evaluation revealed creamy white subretinal lesion over the posterior pole with ill-defined margins suggestive of a choroiditis. There was dome-shaped elevation with over the macula, suggestive of exudative retinal detachment. The OCT showed submacular choroidal thickening and elevation. In the left eye, there was slight blurring of the nasal disc margin. However, the rest of the retina was within normal limit. The OCT showed increased subfoveal choroidal thickness, which was measuring up to 307 micrometers. A non-reactive MANTO, unremarkable CECD thorax, and an absent antecedent history of ocular trauma ruled out tuberculosis, sarcoidosis, and sympathetic ophthalmia as the leading differentials. The fluorescein angiography of the right eye showed diffuse leakage with pooling of dye over the macular lesion with a hot disc and peripheral vascular leakages. In the left eye, multiple pinpoint hyperfluorescent dots were seen in the peripapillary area. Indocyanine green angiography showed blocked cyanescence in the areas of exudative detachment and hypocyanescent dark dots in the peripapillary area of both eyes, which turned to iso and hypercyanescence in the later phases, suggestive of partial thickness granulomas. The patient was provisionally diagnosed as a case of incomplete warped Koinagi-Harada disease, who underwent partial treatment already, and the patient was again inducted on IV methylprednisolone. After 2 doses of IVMP, the visual acuity improved to 20 by 200, and after 5 doses of IVMP, there was significant reduction in the size of the choroidal lesion. She was switched to oral steroid with immunosuppression, and after 1 week of oral steroid with azathioprine orally, the visual acuity improved to 20 by 125 with significant reduction in the size of the choroidal lesion. And after 2 weeks of oral steroid with azathioprine, the visual acuity finally became 20 by 80 with complete reduction in the size of the choroidal lesion and restoration of the foveal contour. Repeat fluorescein angiography at 4 weeks of treatment showed a decrease in the level of hyperfluorescence of the lesion and decrease in the appearance of the disc. Thus, we want to conclude that solitary choroidal granuloma with overlying neurosensory detachment as a presenting feature of VKH is rare. It might have stemmed from abrupt cessation of elsewhere started corticosteroid. And what we want to convey is that morphological characters are liable to change with partial treatment and chronicity. Thank you.
Yes, nice case. You showed a follow-up FFA after 4 weeks with complete resolution. VKH is a stomal choroiditis. For you, the ICG might give you more insight information about the choroidal granulomas, and 4 weeks the FFA may look normal, but your ICG will pick up multiple choroidal granulomas still. So it will be in the subclinical stage, and immunosuppression definitely plays a role.
Yes. Thank you.
Thank you.